dental and medical merging together from a reimbursement perspective, from a care perspective, has been a topic of conversation. What motivated PDS Health to take the step, and what has that strategic initiative look like as it's played out?
All of oral health care is, whether it's now or going to be reorganizing itself in order to come out with better health outcomes. Ultimately, by the way, it's because patients will demand it. Gum disease, periodontal disease, it's one of the most common chronic inflammatory diseases, one of the least treated chronic inflammatory diseases. So over 70% of the population is walking around with gum disease, and the majority of them don't get it treated. We know the impact it has on all of us, but certainly for someone with diabetes. If those who don't get it treated could get catalyzed into care, if we could just get them into a dental practice, and when they get in the dental practice, if they could get their gum disease treated and actively managed, we knew their hospitalization rate could drop upwards of 30%, 30. In our own ecosystem, PDS, using our data with Epic, and we're doing a research study, we have seen 19% decrease in medical encounters for patients coming into our ecosystem with diabetes who get their periodontal disease treated and actively managed versus those who don't. We know that there's untapped value in a dental practice in neighborhoods around the country.
Welcome to the Analyzing Healthcare podcast, brought to you by Scale Community. Scale is a global healthcare-focused member network where healthcare leaders come to connect, learn, share ideas, and shape what's next in our evolving healthcare landscape. To take advantage of all that Scale Community has to offer, from expansive content to virtual and in-person events to interactive peer networking opportunities and more, check out Scale Community at www.scale-community.com. Membership options range from free to paid, so if you enjoyed today's discussion, please take a moment to sign up for your preferred membership level. Welcome to the next Analyzing Healthcare podcast episode by Scale Community. I am pleased to be joined today by Daniel Burke. Daniel is the Chief Enterprise Strategy Officer of PDS Health. PDS Health, formerly known as Pacific Dental Services, rebranded over the past few years as the company moved to a more integrated dental plus broader medical care business. But today, my understanding is the company PDS Health provides care to more than 1,000 dental practices, has more than 800 dentists under management, sees more than 7 million dental patients per year, and on the health side, provides care at a network of facilities under the integrated care model. I think, Daniel, correct me if I'm wrong, across 4 states: California, Arizona, Nevada, and I may be missing one.
On the medical side?
Yeah.
Yeah, primarily right now it's Arizona and Nevada.
Got it.
We've got some smaller things brewing in some of the other states, yeah.
Okay. So before we get into integrated care, which is a super interesting topic, and I think definitely something that stood out about PDS Health, so I want to understand it more, but I want to spend a couple minutes on the history of the Pacific Dental business, just to understand the roots, because clearly there's something unique going on there if you ended up pursuing something as innovative as moving into integrated dental plus medical care. Can you give us a little history on Pacific Dental and what made that company as a DSO special in terms of structure, in terms of growth strategy, in terms of culture, in terms of medical care, just as context for the organization?
PDS, as Pacific Dental Services, started over 30 years ago. Steve Thorne, the founder and CEO, still founder and CEO, started as a lot of startups do, without the intent to build what is today in mind. He started working for his dad. His father's the dentist. His brother's a dentist, by the way. And and that was really early on. He was going to put in a computer system into his dad's office and realized, hey, I really need to understand the operations and the flow of what are we trying to systematize here. And did quite well with that. Pretty soon, speaking to his father's friends and others, he realized he had a business there if he wanted to go for it. And how it came to be Pacific Dental Services was his first office was with Dr. Carol Gazal, who's the first owner doc of PDS. So he went in with her, and she's still here, by the way. It's one thing that's remarkable about PDS, because it's grown organically for 30 plus years, basically no acquisitions. I mean, a couple of footnotes here or there over the 30 years, but generally all de novo, opening new offices. It's had a remarkable long tenure and loyalty. So most of the owner docs who started with us 30 years ago are still here. And so it's pretty remarkable. But it's been a story of de novo growth, job creation, really staying focused on what drives the business, and that is being the best alternative for practicing dentists. So the reason for being originally was to help dentists do more of what they wanted to do, which was practice dentistry at the top of their practice. What set PDS apart from the beginning was early on it realized that comprehensive care under one roof, oral healthcare, was a better model for patients. So early on started bringing specialists into a general practicing dentist, and then started building out for that so that you'd have periodontists, endodontists, oral surgeons, orthodontists, and pediatric dentists all working together in a clinically collaborative environment. So that was very patient-centric. And the owner doc model, just from the beginning, just where the owner doc, it's their name on the door, they have real skin in the game, they are the owner of the clinical practice, so it avoided the kind of the suits versus clinicians environment that had crept up in some MSOs that predated the DSOs. I think Steve was able to learn from that and see that he needed a model where everyone was in alignment, ownership at local level, localized decision making, really being clear around the model of the role of the DSO and the role of the clinician, and then aligning interests. Well, I've been with the company about, going on 15 years, and I remember when I first got here, I had my incentive was largely tied to how well was the organization able to increase owner doc value at the practice level. And we actually measured the amount of profit distributions the owners were taking, and we had to increase it by a certain percentage for those of us who worked in support to get our bonuses. So just little details like that, always keeping in line with the dentist. And I'd say the last thing would be Steve has to date not taken any money outside of PDS, no VC or private equity. So he's been able to really chart his own course, and that's allowed him to be a big investor. So PDS early on went first to go all digital, first to go CEREC, milling units of crowns on site, a number of firsts with saliva screenings, Epic as our practice management system. And so we've been able to make really big bets over the course of our years to ensure that we were able to take advantage, or even sometimes with some humility cause some acceleration of evolution in oral healthcare. So I'd say that's us in a nutshell. And now we're known for trying to integrate within the four walls of a dental practice, and then either physically or digitally creating pipelines outside into the medical community so that a patient can have full collaborative care around a data set. So that's
So sticking with just the dental business, just
sure.
for a bit longer. I mean, there were a couple things that stood out there, and a lot of the dental market has obviously dental market's a broad market, and so there's stories of success, there's stories of challenges, but there has been a fair amount of turbulence across the market with businesses that have either been underperforming operationally or may have got the balance sheet wrong and are over levered. And so, things that I heard that stood out, high degree of continuity. You talk about a founder who's still here 30 years later, another member of the senior executive leadership team that's here just as long. And so continuity, alignment. It sounds like all 800 doctors are owners, at least in their local market clinic. Is that a fair statement or not
Yeah,
necessarily?
on the GP side of the GP dentists,
Yep.
there are well over 100 owner docs in over 1,100 practices. So, and that's just a reflection on our primary model is one owner dentist within their practice.
Yep.
There are some that have that sort of special sauce where they're able to open and have multiple practices. So we certainly support a lot more than 800 GP dentists, because of course those dentists employ associate dentists, and they also bring in
Yep.
specialists.
You mentioned de novo. It sounds like
Yep.
almost entirely de novo, which stands out. A lot of the balance sheet issues had to do with acquisitions that were purchased on a certain expectation that didn't manifest for one reason or another. Buyer issue or seller issue or integration issue. You've gone a different route and gone all de novo, and then a culture. And this was actually one of my questions I was going to ask you, but you already answered it. Is a culture of innovation. I was going to ask if you sort of stuck to the roots and scaled something with consistency over those 30 years or whether innovation was part of the 30-year story, and it clearly sounds like innovation is. So lots of fundamental differences that sound like they would contribute to a happy culture, um, and good outcomes. And so what outcomes was Pacific Dental able to achieve? Low turnover is one. What about in terms of patient outcomes? What about in terms of financial stability? Are these things that you enjoyed over time, or was the market were the market challenges impacting your business as well over some of the recent years?
Sure. I'd say, every business has challenges over years, of course. I don't know of another company in our space, and then we can even talk about other spaces, that hasn't been built to weather those external forces better
Mm.
than PDS right now, right? And that I don't take it for granted tomorrow, but I'd say it's been a very, very strong company. It's been intentionally underlevered. It's been intentionally stuck to traditional banking and financing, and I think we enjoy a very strong reputation. And if you look at our, sort of where we are versus our peers, I think we come out favorably on that. I think the banking world recognizes that. But I think a de novo strategy is hard, and it's hard to do it on scale. It's hard to, we'll open over 100 practices this year. It's hard to do that, and you need to build up a machine over time. The benefits of that, of course, are we can build out a practice for less than it would take to acquire a practice. So some have asked us, would you do acquisitions? And the answer is sure, we would. And we do on occasion pencil them out. If there's a DSO on the market and potentially in a geography where we don't have a significant presence or any presence yet, we'll pencil it out. And what we've found to date has been it's far more cost effective for us to open our own. As long as we can be attractive to dentists that they want to join us, and that and the associates, by the way, all of our owner dentists were associates. So they know us quite well, and they know what we're good at, and we need to help them on their journey. And if they've come to a point where they know that we can help them on their ownership journey, then that's how we do it de novo. We then go with them to a new practice. If we're able to build a pipeline of talent that wants us to accompany them and we can enable them to get done with what we're doing, it's a no-brainer.
So you're
Honestly.
typically not building a de novo fresh. You're taking a pre-existing physician for your network that you have a relationship with that's in another office, and you're moving him or her to a new location to start a new clinic.
Yeah, it's net new. So we don't acquire any practices, even with one of our current associates. That associate would say, hey, I'm ready for ownership, but we have, of course, all sorts of leadership and process for that. And once they're through that, they will have identified, and we will work with them to identify locations where we think would be a great location for a dental practice. So that's
Got
how
it.
we go
Cool.
in.
So you're sort of a splitting model to some extent, where you have an associate at a pre-existing location that's ready to branch out on their own, and you have perfected the model for helping them to branch out, but you've de-risked the relationship because you already know this provider, and presumably you've de-risked is the patient volume there at that point as well.
Yeah, 100%. And what's cool about the model is that organically built over time created mechanisms that reward the owner doc of the first practice when their associate is successful and goes to a new practice.
Yeah.
So it used to happen informally where the associates would say, hey, I need to come up with a certain amount of capital for a new practice, of course. And they would look at their owner and say, hey, would you be a source of that capital? Or would you help me, because you've been doing this very successfully, I've learned under you, would you help me in my new practice? And that over time became actually semi-formalized, where
How
it's
did
not
you
a
handle
requirement.
how did you
Go ahead.
handle the growth across geographic lines, moving to new states?
Sure. It happened originally, it happened more like a wave, kind of organically. At some point we were fairly, I won't say dense, but I'll use the word with a small d, in Southern California. And at some point there were folks who were interested in Phoenix and they were interested in Nevada. So we were able to have our existing dentists of that pool who would be interested in going, some of which moved, and some who said, hey, I'll do the commute. I'll go back multiple times. I'll help germinate. I'll help get the practices going. And so that's how we did it.
And I don't know if you have the answer to this or not, but is there has most of the growth in that 1,100 practices happened in the first 10 years, second 10 years, last 10 years, evenly dispersed?
Yeah, no, it's been accelerating. If
Mhm.
you think about it, obviously when we had 100 practices, we weren't opening 100. Now that we have 1,100, we are certainly looking to ramp our de novo each year. to think about it one way, I'd have to go back and look. We just passed $3 billion in aggregated revenue last December, right? So we'll end the year in revenue over $3 billion. It'll take us probably 4 years. Actually, let me think about it. Probably, let's call it, I'll be conservative, 5 years. We'll double that. So if you just that pace of growth quickens, but we're working from a larger pool.
Makes sense. Makes sense.
Yep.
So very helpful context, and I'm just trying to get a flavor for the
Yeah.
culture and foundation of an organization that then takes the next step, which is to move beyond dental. So give us a flavor for how that evolved. When did that thought
Sure.
start? What was the motivating factor, and where do you stand in that process?
Yeah. And you know what? You'd asked earlier, alluded to like what makes the engine drive and acquisition versus de novo, and what are the rewards or the benefits of the de novo model and all that. I'd say one thing, just for people, because I've been asked that a lot and compared with certain peers who have grown, smart folks grown through an acquisition model, is what I tend to find is it starts with how you look at our business. And if you understand our business is relational, that expresses itself in transactions, then you'll understand our business. If you start by thinking it's sort of an aggregation of transaction, that it makes no sense. And I don't just mean that for how you grow your business, meaning de novo versus affiliation or acquisition of practices. I'm talking all the way down to what is the role of a DSO, and is it to help dentists to do their transactions without worrying about all this other stuff? That's transactional. And there's nothing wrong with that. The way we think about it is our role is actually to help facilitate a relationship between a dentist and a patient. And we actually map it out, right? We consider ourselves a platform, which when we are operating on all cylinders, our real role is to do matching of a patient who's ready to see a dentist and understands what they're going in for and the value that they could derive from it, and a clinician who's ready to see the patient and ready to deliver maximum value to that patient. And we've actually broken that all down into quadrants, and we've nerdified it to make us look smart. But at the end of the day, we actually don't say that we facilitate transactions. We facilitate a relationship. And when you think like that, it opens up a lot about what's obvious to us in other environments about human relationships in a dental practice. And if you start from thinking about the fundamental thing we do is facilitate a relationship between two individuals who have come together of their own volition, and how do they maximize that, and what do you think about that as far as healthcare and better decision making for the patient going forward, and for the clinician, how do they maximize that? It's not about money, right? It's about delivering healthcare, but also learning while you do it, learning about that person, and you're successful if you have a better health outcome, of course, and done in a way that creates a patient for life. And that's why if you step back and anyone who looks at our numbers, they find themselves starting to ask the right questions by the metrics that we look at, meaning how are we increasing what we call CCX, continuing care. Mm-hmm. So we focus on continuing care, lifetime value of a patient, relational metrics. And what we find is when we focus on that, you end up, of course, there's a business side of all of this, but you end up making the business decisions that drive relationship, which actually ultimately drive a better business.
How much consistency, if we were to walk into your 1,100 clinics on the dental side, how much consistency would we see in terms of design and operational workflows? So everything from physical plan to staffing to operational workflows.
The physical side, you'd see a lot of similarities, right? Hopefully you won't see a fish tank, and by the way, yes, we have, I don't know if we still do, but we have some owner docs who say, I got to have a fish tank. And at the end of the day, we just go, you don't really want a fish tank, but they'll get a fish tank. But in general, they should look very similar. The operational workflow is designed to be the same. And I submit, when we talk about dental medical integration, that there's going to be a gravitational pull towards sameness as far as flow because of patient expectation. And how do you maximize the time that a patient has in a visit when you're trying to do a lot more than simply a traditional dental visit from 30 years ago? So I think there'll be a lot more sameness and flow. Where you see the difference is the clinicians. These are owners, and it's a relational. So you shouldn't meet with a Tron who feels like an employee, because they're not. You should meet with someone whose name's on the door and they have a sense of pride, and they are looking to develop individual relationships with their patients. So by definition, that can't be homogenized. So there's always going to be some level of flexibility in a framework where clinicians will bring themselves and their full selves, professional selves, to that engagement.
With all these, it sounds like relatively small clinics in terms of number of providers. How do you handle a concept like succession planning? So, how do you replace a retiring provider if
Sure.
maybe it's only a one or two provider clinic to begin with?
Yeah, no, it's a great question. It's actually a competency we've intentionally been developing, and I'd say right now we're pretty darn good at it. I think I wouldn't say have said that 10 or 15 years ago. We weren't bad at it. We just didn't intentionally think about it as a competency and a value add to the docs. What we found, and maybe if you think about it, Steve was fairly young when he started the company, right? So he didn't have a lot of gray-haired dentists working with him because there weren't a lot of gray hairs who were saying, "Hey, kid, why don't you help me open a practice?" They tended to be younger peers, at least as far as age. So we started coming up with our first groups of dentists who are looking to retire. What I would say is that we have, and I don't want to say the most or the best or any superlative, but we do have a built-in retirement program for them because of the way we do our practices and the way we have modeled them, where they're an owner, so they have an opportunity with an associate to groom an associate rather than to go open a practice, but to take their practice over. And the structure is flexible so that they could actually have an associate start making investments into the practice over time, which might be a win for the retirement plans of the owner and can also be a win for the associate because it allows them to take bites over time, which our practices in general tend to be fairly profitable and valuable over time.
So really, because you have developed this de novo program, this muscle across
Yeah.
your organization, you've actually turned something, for a different use case. It sounds quite similar. Instead of going to a new clinic, they're just going to a pre-existing clinic. You had to create the transition structure, but it sounds like you were at an advantage because you were used to migrating your physicians around, building new facilities, and you just use that in the case of retirement to solve for succession. Healthcare leaders, if your revenue cycle management is underwhelming you, it's time to rethink your current suite of solutions. Scale Healthcare's AI-powered RCM solutions are purpose-built to protect and accelerate revenue across the entire lifecycle. Denial Shield is an AI solution that proactively prevents and automates the resolution of denials, stopping revenue leakage before claims are even submitted. Front Desk Shield supports preclinical, administrative, and front-end RCM functions, incorporating eligibility, prior authorization agents to eliminate friction early in the patient journey. Revenue Shield maximizes revenue by automating coding, charge capture, and revenue integrity functions, ensuring accurate and complete reimbursement. Together, the Shield suite helps organizations reduce operating costs, capture missed revenue, accelerate cash flow, and increase productivity without ripping and replacing existing systems. If you're ready for immediate ROI and measurable impact, visit scale-healthcare.com and see how the Shield suite is redefining AI-powered RCM.
Yeah, and we have a number of the owner docs who are, I mean, as you'd expect, after 10, 20, 30 years, there's a lot of tight relationships throughout the organization. Yeah. I'd say it's one of the things I'm particularly proud of is seeing these docs reach to a certain point, and they share, of course, with the company, with the operations teams. Hey, I'm thinking about retiring, and the longer they can give, the more flexibility they'll have and optionality, and they could hire associates, choose their associates, have great handoffs, and I think they think about PDS supported practices, giving them a number of ways to derive income and really build wealth over time. And the practice itself is the number one wealth generating vehicle for them.
So let's jump over to the integrated care side of
Sure.
your business. It's a topic, dental and medical merging together from a reimbursement perspective, from a care perspective, has been a topic of conversation for some time. Some of the MA plans have accelerated that with different benefits and programs that they offer. What motivated PDS Health to take the step of saying this is going to be a formal strategic initiative for the business, and what has that strategic initiative look like as it's played out?
Sure. So it starts with science, right? And it's fairly remarkable in the way that we have a human community have studied our bodies and our systems, how little relatively little science and research has gone into the oral cavity, specifically on gum disease and how gum disease impacts the rest of your system, your body. And it's really only been in the last 25 years. And by the way, yes, I believe as a species we have known that the mouth is connected to the body. Yes, there's been science. I don't mean to say there hasn't, but it's been a remarkable acceleration in the research and science around the mouth, what we call the mouth-body connection or oral systemic health, and around things. The science is compelling that, and it says to us that in order for us all to avail ourselves of this, the current system and paradigm is restricting us from that. It's very difficult for us to avail ourselves of simply better healthcare if you look at the current paradigm where dental is completely balkanized our system. And we could talk about healthcare and gut health and mental health and all these places that we had the word before health, that in some ways it's great for specificity, but if it leads to balkanization, we all know this, it's less care. And oral health is an easy example. And I can shout out some really quick ones depending on the audience may be more interested in
Yeah,
some than
I
others.
think the question is what are the
Right.
synergies that patients, payers, physicians have realized as a result of integration? And maybe before you do that, if you can give us a sense for the footprint of this integrated model.
Sure.
How big is it? And is it owned providers, or are these partner providers, or these hospital systems, all the above? I think those would be two helpful contextual questions.
Sure. So the thing that's driving this, and we could talk about heart health, brain health, pregnancy health, cancer, there's all sorts of things. Sometimes the easiest one is diabetes. So I'll just give you a quick one and then I'll explain why all of oral health care is, whether it's now or going to be reorganizing itself in order to come out with better health outcomes. Ultimately, by the way, it's because patients will demand it. They just, at some point, the patients will not care why we're balkanized. They will just simply demand that they get better health care. So gum disease, periodontal disease, is, if not it's one of the most common chronic inflammatory diseases known to man. It's also, if not one of the least treated chronic inflammatory diseases. So we have disease walking around. I mean, some numbers, depending on your age, could be over 70% of the population is walking around with gum disease, and the majority of them don't get it treated. We know the impact it has on all of us, but certainly for someone with diabetes, I'll give you an example. The vast majority of people with diabetes have periodontal disease. The majority of them don't get it treated, and that's the United States. If those who don't get it treated could get catalyzed into care, in other words, it's a known person with diabetes, we know they have periodontal disease, if we could just get them into a dental practice, and when they get in the dental practice, if they could get their gum disease treated and actively managed, we knew their hospitalization rate could drop upwards of 30%, 30. Massive. In our own ecosystem, PDS, using our data with Epic, and we're doing a research study with a well-known academic institution to publish this, we have seen 19% decrease in medical encounters for patients coming into our ecosystem with diabetes who get their periodontal disease treated and actively managed versus those who don't. So significant numbers. Then the dollars, and by the way, anyone who wants to Google any of this stuff, there's a ton of reports and on it, peer-reviewed studies, or you can just go to like Aetna or any of the big and large insurance companies who have both medical and dental and just see the plans they have and the data they show and how they're trying to catalyze their members who have periodontal disease into care because they're seeing such significant better health outcomes and therefore lower costs on the medical side. So I can give you any other examples you like on maternal health and all these things, but at the end of the day, we know that there's untapped value in a dental practice in neighborhoods around the country. So that's where we started the premise. And then from the premise was, well, how do we, as I hope I don't sound grandiose, as dental practices, how do we then unlock that value? What does that look like? And can we go it alone? And that's what you'll see that led to us saying, we can do so much on our own, but we really need partners on the medical side. And like we chat about the different models that we have tried and are currently working on. And then we also said, you know what, at the end of the day, if we could do both, be on both sides of that, both the primary care and the medical, and the dental, we could really drive the collaborative environment and see ourselves better health outcomes. So we've got multiple models.
And maybe this would get to the models question, because I was going to ask: is when you use the word integrated care, is it physically owning primary care? Are you employing endocrinologists on the diabetes side, or is it integrated where you're partnering or sharing data and more strategic partnership, flow of patients, flow of clinical data, things of that nature?
When we sketched this out, we made a visual of it. We had the patient in the middle, right? Of course. And then around the patient was their data, all of their individual data. And then, of course, that was the population health data. And then we had as puzzle pieces around that, the different clinicians that would need to collaborate around that data set for that patient, right? We didn't color PDS across those other puzzle pieces. We kept oral health care. That would be our lane. And we said, okay, in order for this to be realized for the patient, we need to be able to contribute data and extract data. That's what led us to Epic. So the first big move was being, to my knowledge, the first dental group of any size to go on Epic. And that unlocked a ton. We have tens of millions of records being virtually pulled and shared across within our dental practice, but also within medical. And of course, Epic is also CVS, Walgreens, or Gross Cross Pharma as well. So we unlocked that with Epic, and we continue to work on that and get better at it. Our clinicians' ability to pull relevant medical data, and our clinicians' ability to put in information, data, notes, et cetera, that automatically get pulled then on the medical side. So that's the virtual collaboration. That for us we don't have a model that disrupts that or ends that. That's real, it exists, and it's better for all of us. And we could talk about some of the enablements we need on both sides to have it be intuitively smarter system over time, so that the information that your clinicians need about you is available in that moment, ultimately available to you as well. And then how do we rationalize that?
Okay, go on. Let's hear the second.
Sure. Then the second was, all right, now we've got groups out there that are on Epic. We didn't think initially, hey, let's go build it ourselves. We said those who are already doing it, we're sharing data, but it's a little sliding under the door, right? We're not actually actively communicating. So we started talking to some medical groups, and we ended up talking quite a bit with one in Southern California, Memorial Care. They're from Long Beach down to San Diego, and they're on Epic. And their chief clinical officer was quite aware of the oral systemic link and was very interested in how they could catalyze their patient population into oral health care and otherwise. So we have a multi-layered relationship with them. We do have one practice, a PDS-supported dental practice that is embedded in a Memorial Care medical environment. Otherwise, we do a lot by offering dental services to their actual employees. And I don't remember their patient count, but it's well over 10,000. And so we're actually able to see their employees who see their medical side and us on the dental side. Not all of them, but that's the choice, right? But we're able to work on those numbers in those people to prove out different cases. So we have a multifaceted relationship with them. I would say that's one of the models. And what we ended up also saying is that there's multiple ways we could be doing this directly ourselves. So we've been for a number of years, and we started out quite small. We're very much a learning institution. Not that all DSOs aren't, but I think we might look a little bit different on the inside. We borrow a lot of best practices from other industries and in healthcare. So we tend to experiment, and then we have a whole process of experimenting. If we're going to deploy out, we do the alpha 1, alpha 2s, betas, deployments, and all that. So in the test phase, we actually engaged an MD in Las Vegas, and that was the first time. So we actually had one practice that had medical on one side, dental on the other. And we found that to be a very strong model for us. As you'd expect, the physical proximity, the shared environment, it's immersive for a patient, so they'll see that they are in a place of systemic health. They'll literally QR codes on the wall, so if I have diabetes, and I'm there to see the MD side, or if I'm there to see the dental side, I can learn about the relevance of both. We've found in that environment, when an MD does a simple oral exam and talks to their patient about seeing the dentist or when's the last time they saw a dentist, when the nurse practitioner or the medical professional recommends that they see the dentist, their show rate's well over 90%, which is remarkable, and they tend to get the needed dentistry done. So in dental world, as opposed to medical world, and lots of reasons for this, the payment system and others, case acceptance is actually something that people pay a lot of attention to. Like if you go to a pediatrician, you bring a child, you tend not to think about, hey, the pediatrician recommended something. Most parents then take action. In the dental world, on average, outside of our ecosystem, it's about 25% of the time patients actually do the recommended care. It's a remarkable number. But what we find is when someone from the medical side sees a patient, whether it's their current condition of their mouth or their history or whatever it is, and says, I recommend you go. And by the
Right.
way, particularly have them look. I'm thinking I'm seeing some inflammation in your mouth or in your gums. The case acceptance number is significantly higher. So it's remarkably successful
So
in that
just to
way.
make sure I have the models correct, it sounds like the first model, I'll call it passive partnership, where you've
Mhm.
got different groups that are both happen to be on Epic. There's an opportunity for information exchange, but you see your patients, they see their patients. Information exchanges, you're both better informed, but there's not a whole lot of deliberate collaboration on patient care beyond that. Model number two sounds like it's more structured collaboration, it's partnership, and Memorial is an example of that, where really you're doing the same thing, but there's a more robust structure and proactive coordination. And then model number three is ownership, which sounds like it's quite effective because it's very integrated. I would imagine it's probably the most difficult to scale or most expensive to scale, or maybe I'm wrong on that. What are your thoughts on the
Yeah.
role of that third model over time?
By the way, footnote on the virtual, where it's
Yep.
just, each doing their own focus factory and just have data going back and forth. What we've found is, and it's anecdotal, is we've seen a number of folks on the medical side or a dentist actually reaching over the chasm and making a direct connection and saying, hey, one of my patients is seeing you. Here's what I'm seeing, and beginning to collaborate.
How do they know to do that in the passive model? Is there a care management team that you've built out? Is there some kind of AI algorithm that allows you to harvest the data to know which patients? Like, what's the catalyst for that provider on the hospital side to know to reach out to your organization?
By the way, that's a great question. The medical side is further along that journey than we are on our
Mhm.
side, if I call us dental for now, right? We don't have the teams that, say, medical is incentivized to have now to reach out and do that. So at this point, our system, it's Epic, is smart, so it makes suggestions and things, and that'll continue to get better. Epic's quite good at it. But it's really been organic where you'll have a patient, you'll have a MD seeing a patient. I'm thinking of particularly actual stories. Well, they'll see a pregnant patient and they'll see significant periodontal disease, and they will actually put a note in, or through via the patient or direct, actually reach out to the OB and say, here, I wanted to alert you, here's something I'm seeing. Our practices also do saliva screening. So
Mhm.
they may actually reach out and say, I'm seeing elevated FN, which is a bacteria associated with low birth weight preterm, and speak to the OB about what they're seeing and what they're recommending. Or you'll see an OB reach out and say, hey, I just saw in my patient's record that they did a saliva screening, elevated FN, or you're seeing periodontal disease. Let's talk about that. What types of inflammation are you seeing? And
So for now,
all
either
that.
the doctor on one
Right.
side or the other knows to do it, or Epic is making a recommendation based on the clinical indication.
Yes, what I think will happen in the future is medical will build more of their muscle with oral health there. And I think the first one to do it, I think if they're not doing it already, will be Kaiser.
Mhm.
I mean, more care, love them. But Kaiser has been on Epic quite a while, and Kaiser is in dental in the Pacific Northwest, and they have their own dental practices. So they're developing this over time, that muscle memory as well.
So back to the question on the
Sure.
the ownership model. Do
Yep.
you see that growing and weighting in your portfolio, or do you like the partnership models one and two more in terms of achieving scale faster?
I think what'll decide it, and I think I know where we'll go. Is I think we'll do both. By the way, and not to be Pollyannish, but if we really believe, and we do, that dental practices have untapped value for patient health in communities, and I can share with you some of the stuff we're doing outside of the things we've been talking about, and that our role is to help enable that to happen, and then of course championing the dentists, who are our customers, in order for them to capture some of that value, which we think would be appropriate. Then we would do all of this because it would really be the most impactful for patients. What we're finding in the different models for us is having a co-located medical professional, and I'll give you a real example. In Las Vegas, what you'd see is think of it as a hub and spoke, where you'd see sort of a hub practice where you'd have full co-located, and then you'd have some embedded nurse practitioners or other medical professionals in existing dental practices. And we're seeing success in that model.
Let's talk about stakeholder reception to this
Sure.
integrated model. So payers, hospitals, patients. I would imagine the patients are happy. It doesn't sound like there's much downside to the patient to have integrated care. Am I missing something on that?
No, I'm glad you said it. One of the things, and I would say this out loud if there's folks in oral healthcare and maybe healthcare writ large, is we tend to overthink the patients. We have found, and trust me, some of this was painful learning, is how obvious this is for patients. There's just no pushback. We spend a lot of time, things like saliva screening, on how to introduce saliva screening to patients, and do we need to teach them AP bio, and do they need to understand the chemistry of an activated MMP8 and collagen breakdown. And what we found was patients, especially after COVID, they understand a quick saliva swab and there's valuable data and information in there, and they say yes, right? So easy example. Integrated care, same thing. They think it's obvious. Of course, the mouth's connected to the body, and they generally nod their head and say yes.
I guess the only thing would be if their primary care provider is not part of your
Sure.
partner network, then they
Yep.
but at worst, they don't take advantage of the integrated care model. But if they do, it seems like a clear improvement. How about the payers?
Sure. The payers have been waiting for this. And the easiest way to see it is, again, you go to Aetna or any of their websites. I'm just thinking of Aetna right now. I was just talking to one of their leads. They have been actively trying to get their patients with certain comorbidities, heart disease, diabetes, pregnancy health, brain health now. Cleveland Clinic's a good source, by the way. They've been actively trying to catalyze them into care, but the issue on the payer side is that they themselves are balkanized. So you've got, if you actually go to visit them, dental's on a different floor, and then medical's all these floors, that dental's here. And dental is, as insurance, is not really insurance, so there's not really a risk-based thinking about it. It's really about a coupon to help. I don't know. I don't want to be too cynical because it's not a bad thing, but it's kind of an afterthought with employers. It's an afterthought in a lot of places. But if you talk to the dental directors of these insurance companies, they have been trying to shout from the rooftop to get integrated care. And if they could catalyze patients into an integrated care environment, they know they'll have overall lower costs.
Yeah, and it sounds like maybe the excitement based on the reduction in hospitalizations would
Yep.
be more on the medical side in terms of care
Yeah.
care avoidance. So how has their receptivity manifested? Have they gone out of their way to modify your reimbursement model? Are you
Mhm.
participating in global risk alongside, or some type of bonus program so that you're sharing in the lower cost for the hospital avoidance, or is that work ahead in terms of figuring out what the pro forma reimbursement model is?
Yeah, no, we're actually keenly interested in those models. We're keenly interested in value-based care. We're keenly interested in ultimately sharing risk because we're quite confident of the science and the better health outcomes. We're not currently to date, but our system is moving towards that. Some real concrete examples. So Delta Dental, they're a fascinating group to look at, right? They're well-heeled, tons of investment. They're not a monopoly, but they certainly have pole position with employers and brokers and all of that. So more power to them. For them, there may be in some ways a existential threat. Integrated care, where the spend is on the dental for gum disease treatment, keep it simple, and the savings are, to your point, is
Right.
realized on the medical. There's not a lot of incentives for dental to want to pay out more.
Right.
Usually, Delta Dental doesn't win prizes from employers if the spend goes up, right? But Delta Dental is very smart, and so if you just want to Google this, you could find out what are all the things that Delta Dental's doing to demonstrate their value in an integrated environment. And I'll give you two examples, and they're both with us. One is Delta Dental of Arizona. They're actually paying for our clinicians to do A1C testing in our dental practices in Arizona. And they're paying for them not just for Delta Dental of Arizona members, but for all patients, which is remarkable, right? They're doing it because what they know is that what they're doing is they're championing the role of dental practices and community health. And I'm sure they have a thesis by which at some point that will benefit them, right? Of course it should, by championing the value, the untapped value of a dental practice. So what we're seeing, by the way, is we're seeing, I think it was 28% of patients are coming into our practices, don't have and this is dental practice in Arizona, don't have primary care and don't see primary care. So these are patients that are, nobody's tracking them. And what we're finding is that, probably a coincidence, but about 27% of them are either pre-diabetic or diabetic, and the majority of them don't know it. So what Delta Dental of Arizona is, they're sponsoring a study that is demonstrating the untapped value of a dental practice to identify and capture these patients, make them aware, and bring awareness to the patient. Ultimately, through PDS and Epic, we'll be able to bring awareness to their medical providers that they may be pre-diabetic or diabetic. Obviously, dentists don't diagnose it, but they can take the A1C. So Delta Dental of Arizona is actively investigating for itself what role can it play, and they're smart.
Are there any examples of dental insurers collaborating with medical insurers where maybe there's a financial exchange or risk exchange at the insurer level?
Yeah, the easiest way to see it is those who are on both sides, like United and Aetna and Highmark and others. Aetna and others have how they do it is by plan design. So if I'm an Aetna medical member and I have diabetes, they will pay full UCR, which is like the undiscounted rate that dentists publish, right? And
Yeah.
then they get 40% of it or whatever, right? They pay the full UCR and additional treatments for patients with diabetes in a dental practice. So Aetna is doing it. So Aetna will spend the money on the dental side because they have them on the medical side. And where you're going to see that continuing, and you're going to see it become easier for patients. And that's what I meant by putting pressure, and I'm being a little dramatic, but existential pressure on Delta Dental, because they need to find their way through joint ventures or other ways to facilitate that while keeping their seat at the table.
So we talked about patients, we talked
Yep.
about payers, we sort of talked about reimbursement on the dental provider side. It sounds like you're
Yep.
being compensated for additional care that's strategically relevant to this integrated care ecosystem, both by sort of these payers that are on both sides, like a Aetna or United, as well as just a pure dental insurer on the dental side. How about for the hospital systems? When you approach them, is this something that immediately resonates or falls lower in their strategic initiative stack? How excited are they? How keen to invest time and resources into building out the model are they?
Yeah, I think the biggest challenge for medical dental integration is the capacity on the medical side, right? You nailed it. I think for say primary care physicians, they've got a parking lot full of people with signs above their heads outside their office saying, if you could just do a social determinant check, if you could just talk about diet, if you could just talk about mental health, are they seeing people? There's so much demand, and I'd hate to think, but I think at times oral health is like that. We're out in the background saying, if you just do a simple oral exam, So I think the biggest challenge both for primary care physicians and for hospitals is just the remarkable amount of demands on them and their time with patients. What gives me a great deal of optimism is the physician fee schedule that was just published. So it just came out last fall and it's now in effect, 2026 now, is for the first time the physician's fee schedule in the back, where there's a whole bunch of things that physicians can sign up for to be measured for value-based care programs. For the first time now is a simple oral exam and refer to a dentist. This could be the mouse that roars, right? Because up until then, you hate to be cynical in healthcare, of course. These are, by certainly good actors, but sometimes what gets paid for gets done in the reality of it. And this will be the first time that primary care and physicians would ultimately get paid to do a simple oral exam and refer to a dentist. That's a really big deal.
I want to end on sort of a broader, maybe more academic topic of innovation for PDS Health, because it sounds like that's been core to the culture for 30 years, maybe most recently manifesting in this integrated health. But on the dental side, you were innovating in different forms. You mentioned a number of firsts earlier in the conversation. How, as an organization, do you think about um, sort of healthy, balanced innovation where you have 1,100 practices? That's a lot to manage. It's easy for these clinics to go wrong and underperform. Balancing sort of stability, performance, and being really good at something that's highly repeatable versus maintaining a fresh culture where you're staying ahead of the market. You're introducing new concepts that advance patient care, that keep you relevant with payers, that keep you relevant and pushing with strategic partnerships that expand your footprint in your ecosystem. Because lots of groups, whether it's acquisitions that go wrong or investments in technology that don't pan out, they don't get that balance right necessarily. And so they either do too little of the innovation and get outcompeted in the market, or maybe they do too much of the innovation and they end up spending a lot of time and money down the drain on failed initiatives. So how have you found that balance at a pretty scaled level, 3 billion growing to 6 billion any day now?
Sure. Yeah, I think structure can either enable strategy or trump strategy, right? And we are structured for innovation. So we have PDS Health, right? As of about a year and a half plus ago, we renamed ourselves. Underneath PDS Health, we have a number of business units, one of which is PDS Dental, call it a DSO. We have PDS Medical, the MSO. We have PDS Specialty, which is like an SDSO, which is specialty dental. So we now support directly endodontist groups, periodontist groups, oral surgery groups. So that's on the healthcare services. But then we also have PDS Investments and PDS Innovations, and they're kind of a brother sister, right? Those exist because if we are to do if we're to achieve our vision, which is to create something different and better, we need things to come along our journey that don't currently exist. And that's the brother sister. So PDS Investments goes, and we have our ears open for smaller startups, innovative companies that could help us. And so we supply them with some capital, financial capital, but otherwise us, right? And who we are and what we know, and we try to help them. The sister to that is PDS Innovation, which is actually a group, and we keep them geographically separate, and they're propeller heads, and they have invented things, and they came up with, digital payment systems. They came up with 2D imaging, AI on 2D imaging, and sold it because we decided that we would now compete those who would be dedicated, so we sold it. So they're constantly working on new technologies that'll help us on our journey. And then we have a PDS Plans business, because plans, we need to work with them differently. And then the other one is PDS Health Tech, where with Epic, our relationship with Epic, we're actually able to deploy our instance of Epic to other DSOs and to dental schools.
It sounds like a key has been recognizing how many different businesses you're really running. And
Yes.
I would imagine each of those businesses are supported with leadership for that division and ample resources. But I think it sounds like beginning, or it begins with recognizing that you're in 7 different businesses and that they each need the resources they need and the business plan they need to succeed.
Yeah, and we need to make sure that on 2 levels that we have a consistent executive leadership team, right?
Yep.
And it helps to be a founder-led organization. I don't have to think about the CEO we brought in from Procter & Gamble, and then the CEO after that we brought in from Enterprise, and it's Steve. And Steve is a very mission-driven person.
How big is the innovation team, and is it mostly AI developers or other kinds of skill sets?
It's multiple skill sets. They work on a number of things. In fact, some of the things I will jokingly say I don't officially know about because we give them a room to just break stuff. But good question on headcount. I don't know what their headcount is now. I honestly don't know. 30 to 60 people. I mean, it's a good sizable group. Yeah. They don't report to me. I just get a kick out of them.
Well, Daniel, I want to thank you so much for giving us a glimpse under the hood at PDS Health. Super interesting conversation. Very interesting what you're doing and pushing and advancing with integrated care. So it sounds like a wonderful organization with a very unique history, culture, and strategy. So thanks so much for sharing.
No, I appreciate it. And if there's one thing for you listeners, those who trudged on through all of it, I hope they'll listen selfishly for themselves, because what I'm talking about mostly here was just operationalizing science that is better healthcare for us. So if they know anyone who's pregnant or trying to get pregnant, please see a dentist, get your saliva screened. Anyone with a history of brain health or cardiac issues, please just do a simple search to understand the connectivity between the two, because all of this is about a better healthcare, and it sounds grandiose, but it really comes down to individual people. And there's better healthcare out there. Unfortunately, now you have to be proactive to go get it. Until we can democratize all this operationally, it will be a need for each of us individually. So I hope listeners, if they take away one thing, it's maybe one thing that'll help them or a loved one have better healthcare.
A good note to end on. Thank you. Thank you again, Dan.
Thank you for joining us on Analyzing Healthcare. Stay informed and stay inspired. Don't forget to subscribe and visit scale-community.com to become a Scale Community member. Until next time, keep exploring the ideas that shape our healthcare systems.